Welcome to another exciting episode of Bodyholic with D. This is episode number 28. Bodyholic with D is the podcast and show where we dive deep into the world of cutting-edge and science-based well-being. I'm your host, D. Katz Shachar, and today we have an incredibly special guest with us. Dr. Pranali Hoyle is a board-certified behavior analyst at a doctoral level whose career has spanned across schools, clinics, group homes, and residential placements. Her dedication to making a difference in the lives of individuals on the autism spectrum made a deep impression on me. Dr. Hoyle's clients have ranged from as young as 12 months to as wise as 75 years, and she is driven by a passion to ensure that every individual receives evidence-based treatment to enhance their quality of life. I must say, my conversation today with Dr. Pranali was nothing short of fascinating. It provided a wealth of knowledge about autism and its unique challenges. Specifically, we explored a topic that is often overlooked, but of utmost importance: feeding and eating challenges for children on the spectrum. Dr. Pranali's insights to this complex area are not only eye-opening, but also incredibly valuable for parents, caregivers, and professionals in the field. So without further ado, let's jump right into this truly enlightening discussion with Dr. Pranali Hoyle. Get ready to expand your understanding of autism and gain valuable insights to the world of feeding and eating challenges. Stay tuned. Dr. Pranali Hoyle, thank you so much for joining me today. I am so excited to talk to you.
Same here. I'm super excited. Nice to see you again, even though we're not in person. It was nice to see you at the conference, and now I'm getting to see you virtually. So
Listen,
awesome.
I love technology these days and how it just brings us, closer together. It's amazing.
Yeah.
And then I get to, have you on my podcast so people hear all the amazing things you have to say. So I actually want to start with you giving all of us a little bit of your background and what you specialize in. And then from there, we're going to zoom in because the topic of today's discussion is actually feeding and eating challenges, especially among children with autism or on the spectrum. And but before that, a little bit about yourself, please.
Sure, absolutely. So I'm Dr. Pranali Hoyle. I have been a behavior analyst for almost nearly 10 years at this point, but I've worked in the field of autism specifically for over 20 years. I started out at the age of 19. So now I'm going to date myself, obviously. So it's been over almost 22 years where I've serviced children and adults on the spectrum across public schools, private schools, clinics, residential, group homes. And I've worked with clients with a range of severity with autism. So I have clients that are completely non-vocal, and then I have clients with great level of very age-appropriate conversation and other skills, but not the social deficits continue to exist. And the treatment that we provide ranges from extremely intensive to, just working on social skills and developing self-management and self-care in those areas. So that's really been most of my experience is with children on the spectrum, but I've had a lot of other disabilities and comorbidities like eating disorders, obsessive compulsive disorder. So it ranges from anywhere from just the diagnosis of autism or diagnosis of autism with ADHD, learning disabilities, all range of different disorders.
So it's not specific. So when you talk about OCD and eating disorder, it's in your expertise, it's coupled with autism. Is that?
So what we find, especially because the diagnosis of autism, if you look at the DSM criteria in specific, autism itself has restricted and repetitive behaviors, and that social deficit is a big component of autism. So
Mm-hmm.
sometimes you'll see overlap of other conditions. And
Mm-hmm.
a lot
I'm
of
sure.
times, especially when children are little, they're not being diagnosed with those secondary disorders until they get to like teenage years or even further into their life
Mm.
cycle. And then you'll see like a secondary disorder being diagnosed because it's difficult to really address that when you're so little, essentially. But
Right.
most of what I see a lot of the times is autism coupled with ADHD because there's such an overlap with those two disabilities.
Yeah, I can actually, that makes sense to me. The little I know, that does make sense to me.
Yeah,
Um, and so regarding the topic of our conversation, um, how do feeding and eating challenges commonly manifest in children with autism? And what do you think some of the key factors are that contribute to the challenges?
absolutely. So, I mean, from what I've seen, what I've experienced, and other professional within the field, what we see is a lot of times children as little as 18 months to 2 years of age will begin having feeding challenges. So currently, the clinics that I work with that provide services to children ages 2 and up, a lot of children that we assess come in with specific feeding challenges, and they can range from mild to very severe. So we have students that just have food selectivity. So
Mm-hmm.
based on texture of the food, the smell of the food, the the even just when they chew the food, they like specific texture. Most of the children that I meet tend to like either really soft textures or really crunchy textures. And then anything that's in between, you have to essentially desensitize and expose them. And then other children who have limited language, especially, have difficulty expressing, like if they're eating a certain food, if their body is having reaction to it. So typically if they have allergies to it, you kind of know right away, right? Because they're going to have a reaction or some
Right.
sort of rash. So you kind of identify those things right away. And a lot of children, especially now, you've seen the peanut allergy is very common, whereas in
Right.
30 years ago that was not the case. We
Right.
didn't really have that prevalence of peanut allergies in children, or even sensitivity to gluten. So we see that a lot too with children on the spectrum. And then sometimes it
Oh,
becomes,
specifically with children on the spectrum, or it just
yeah,
because it's prevalent, it's also
I
children.
think it's a combination of the two. So I think gluten, and specifically gluten and casein, what we see is either they have a high sensitivity to it, or you see like specific behavior changes happen if they have too much of that type of food. So
Hmm.
a lot of times parents will do like gluten casein free diets because they just want to make sure that the kids are eating healthier options. But sometimes it could be as much as an allergy, and sometimes it could be a lot more severe. So like there's research to show like students who have um difficulty with chewing and swallowing, so that can be even more challenging. And then
For
we have
sure.
other professionals who need to be collaborated with when we're
Hmm.
providing treatment to somebody who have internal challenges
Okay.
compared to just
Physical, internal
right.
challenges. Yeah. Hmm.
Exactly. And especially if they can't tell you, right? So if their food is not being swallowed properly through the through the esophagus and all those areas, then it's difficult for a child who doesn't have language to be able to tell you that. So we've had parents who, put their kids in a high chair and try to feed them, and a lot of times, they end up choking or vomiting and things like that and gagging, and a lot of times it looks behavioral, but that's why
Oh, wow.
we always tell parents first rule out medical before we do any behavioral interventions. That's just ethically and clinically, that's always the best practice, obviously. So we always make sure there's not an underlying medical cause for the feeding.
100%. So, what I find really interesting from what you just said, actually almost taken aback, was that there are parents that will first come to you before they rule out. Wow.
Absolutely. Yeah, because sometimes they just don't know. They think that their kid is just being picky. It's because that history of, and parents have other challenges along with just raising a child on the spectrum, which can be challenging on its own. Just raising children alone, obviously,
Right.
is
Right.
challenging.
Absolutely.
Yeah. So even if you have a neurotypical child, there's challenges with that. So imagine
Hmm.
like you have a child who's developmentally delayed, has limited language, and parents just don't know. So a lot of times they will come to us first, especially when we're getting them at such a young age of 2 or 3 years old, where kids tend to be picky naturally,
Right.
right? So it's hard to say whether there's a medical cause, especially like at a pediatrician's office, you're not assessing those things in detail. So
Hmm.
it's really difficult for parents to really understand that medical versus the behavioral component. And we tend to usually send them out first to make sure there isn't a medical component before we provide intervention.
Wow, this is really, really fascinating. Um, when you where so you teach classes on this specifically?
Not specifically on feeding challenges. I mean, when I teach my grad courses, it's more encompassing. But what I have done is provide intervention specifically on feeding challenges. So when I've had clients that I've provided services to in home and in a clinic where we're just working on a feeding intervention and getting the
Hmm.
child to be consuming and exposed to different types of food. I've had one client that I provided in-home services for, and that was the only challenge she was experiencing, but that affected so many other factors of her life because she was unable to make healthy choices first, and then secondary, she was having such reaction to being in environments where different foods were present. So, like school cafeteria was a huge challenge for her, which also limited her capability to have those social interactions.
That's what I was just thinking.
Yeah. Yeah. So that, and then, when she would walk into a cafeteria, she would immediately have like this gag reflex from smelling the different foods and being exposed to different foods that she initially was not consuming. And it took us almost 2 years to get to the point where we can go out to a restaurant and have her there and she was able to tolerate and eat different foods and be around other people eating different foods. So
That's so interesting. It
yeah,
sounds like it does kind of, I mean, again, I'm not a psychologist and I'm not an expert in autism, but for the layman, it sounds like uh there definitely is some kind of overlap with OCD. The
yeah, absolutely. Yes. And OCD in itself doesn't typically get diagnosed until more of the teenage years because you
mhm.
kind of have to have that the compulsion and the obsessions for such a repeated period of time,
Right.
that yeah. So it's some of that and because children on the autism show so many signs of OCD, it's
Mhm.
really difficult to separate out one over the other.
Right. Um, the I want to ask so many questions right now because like you're just exposing me personally to a world that I just am unfamiliar with.
Yeah.
So the is there a specific link between feeding in general and autism, or is it that autism has different obsessions and you specifically deal with one of your expertise is dealing with the feeding and eating challenges?
Yeah.
Or does it always have to, is there always something around food? That's my question. Is that
Um,
typical?
I mean, based on research, there's almost 40 to 45% at this point, children on the spectrum exhibit some sort of feeding selectivity. So most of the children that we get that I assess personally, just within the last week, I had several assessments. I would say more than half of those students had some sort of feeding challenge. So it was either such rigidity to eating certain foods, and it can even be, let's say they only eat French fries, let's say, for example. but then the French fries have to be from a certain place. So let's say you change the type of French fries, then they won't accept. Like if they're only eating French fries from McDonald's and you tried to change it to Wendy's one day, that
Right.
also just in itself be a challenge. So sometimes we have to start even as small as just generalizing to a variety of different types of French fries before we can even move to like exposure to different types of foods. So that sometimes can also be challenging for parents. You know, I have parents tell me like I have to pack food everywhere I go and I have to have these specific things. And you know, at long term, that's almost unfeasible for any parent.
Right.
So it really varies, honestly. But I would say more than half of the students that I assess currently tend to have some sort of food selectivity or feeding challenge that we have to incorporate within our treatment.
And my heart goes out to the parents,
Yeah.
like because all the mom and dad, what they want is just for the kid to get all the vitamins and minerals and be comfortable in life. And but also my heart goes out to the child. It's frustrating. I can only imagine how frustrating it is to see the frustration around you
Absolutely.
and being unable to overcome it. And then there's you who comes along and like saves the day, which is huge.
And it's the problem, the biggest challenge I find is the time component, right? So we can't, as much as we can put in interventions in place and have so many different strategies, positive reinforcement and evidence-based techniques that have been developed, you can't predict how quickly it's going to
For
happen.
sure.
So
You
that's
just
always
mentioned a 2-year intervention.
right. And you know, we systematically increased her exposure to different foods and in different settings. We had to work on specifically how do we expose now the same intervention that we're doing in home? How do we generalize that to her school setting? How do we generalize it to a restaurant, to a birthday party? So like that's another challenge within just the realm of autism. And even I think children on the spectrum or in children, even some children that are neurotypical, you'll see them go to a birthday party and they won't consume food because it's not looking a certain way, or it's a pizza's
For
not
sure.
from a certain spot and it doesn't look the same as what they have typically. So I mean,
Absolutely.
for children on the spectrum, that's tenfold of.
Right.
So you know, generalization is always a challenge for most children, and I would say even more of a challenge when you are dealing with somebody with autism.
Absolutely. And I'm also thinking like autism in general, the social aspect of it is, what is it, the main aspect? Is it the communication?
I would say the social deficits, it's usually that first indicator. So like the lack of eye contact, lack of some joint attention skills. And what I mean by that is like when children first start to play, they always want somebody to kind of see what they're doing. So a lot of times
Hmm.
they'll come over and have you look at what they're doing or even point to what they're doing. Whereas children on the spectrum, they're very content with playing on their own. If they have some initial play skills, they tend to not want to share that
Right.
essentially and be
Right. Very interesting. And then the food being such a social thing in our lives.
right. Exactly.
And so it's like actually sounds very lonely.
Yeah.
Yeah.
Because you realize like the communal act of eating is just there's so much social interactions involved in there. I mean, when you go to a dinner, like you're interacting, you're watching the other person. So even like the sight of another person chewing could be difficult for somebody
Right.
on the spectrum because they're chewing something that's not favorable to them. So
Oh my gosh.
all these aspects, absolutely. And then just being in a new setting in general. So even
Hmm.
if you don't have feeding challenges, just being in a restaurant and being able to tolerate those smells, the noise, all of those components, the lights in the, you know, so all of those components go into play when we try to develop intervention, we think about all of these factors and how do we systematically expose so that the child can be successful in these settings.
Seriously, I'm like imagining you mapping things out and
It's like
like,
a roadmap, yeah, basically, of like how we're going to do this and how we're going to essentially maintain those skills, because a lot of
mhm,
times what happens is once intervention is faded out, that maintaining that over time is going to be crucial too, right?
right.
So we have to also consider those factors, is when we're not there 30, 40 hours a week, when we're down to 5 hours a week, how are
Hmm.
we making sure the parent is confident to really carry these things out into different
Absolutely.
settings? Yeah.
Absolutely.
Yeah.
Wow. This is so fascinating to me. Getting into more research-based science, can you discuss a little bit the research-based strategies for assessing and identifying specific feeding and eating concerns with children, of course, on the spectrum, and considering both behavioral and sensory aspects, like
Mhm.
getting into the more nitty gritty of the science.
Yeah, absolutely. So, I mean, the feeding, there are so many different feeding clinics, and one of the best ones that I can think of is obviously the Kennedy Krieger Clinic, and they do amazing research there. They're publishing such great resources for people in the field, which always blows my mind how
Can you
amazing.
repeat it, please?
The Kennedy Krieger Clinic
Okay.
in Maryland. So they're
Hmm.
one of the top, I would say, leaders in this area for sure.
Okay.
So a lot of times, there's Rutgers University now in New Jersey. They also have a feeding clinic. There's several hospitals that have clinics, and they use more of like that collaborative approach where they go
Mhm.
in. A lot of times, interview based. For me personally, it's a lot of it's interview based, where we initially do the assessment, we talk to the parents regarding skills across different domains, and then feeding is always part of that. So
Mhm.
how does your child consume foods? Are they able to use utensils independently? Do you we try to be absolutely culturally responsive with that, is some cultures don't use utensils. So for us to try to teach a child who might be consuming foods with their hands to try to use a fork or a spoon, because that's what we expect within this culture, but that's
Mhm.
not might be the expectation. So all of those things, we make sure that we're using a very collaborative and culturally responsive approach when we're doing feeding as well.
Beautiful.
And the speech therapist, occupational therapist, depending on which setting you're in, typically in a hospital setting and more of those clinics, they tend to have other professionals and medical professionals that rule out the medical concern first. From a behavioral perspective, we do like parent interviews, then we'll do some sort of assessment to see what are the most preferred foods. And that something like that is called a preference assessment. There's a variety of different ways of doing that as well. So we try to identify what does the kid like first
Hmm.
before we move to what do they not like. And typically we get
Hmm.
that information from parents, and then we see when they're in settings where other children might have those foods, we see what their emotional reaction to that is and make notes of that, and then develop a comprehensive plan based on those results,
Hmm.
essentially. Sometimes we also do something called a functional analysis. We try to figure out what is the function behind the fact that this child is avoiding certain foods. So is it because they just have a repeated history of getting access to foods that are so preferred and maybe not as healthy? So if a
Hmm.
parent, especially if a parent is having so many challenging behaviors, like if a kid is hurting themselves, let's say, and this happens a lot when they are being asked to consume foods that they don't typically like, you'll see challenging behaviors happen where they might be hitting their head or becoming aggressive or throwing tantrums that last long durations, and that can be very challenging for a parent. So the solution with would be to, okay, you're going to get the French fries you want because
Right. That's what I
I
was
don't,
just going to say. I mean,
at some point the parent's going to have that, they're going to hit their essential point where they're like, okay, I really don't know how to get you to calm down, so I'm going to
right.
give you what you need now. So there is that history that happens, and it's unfortunate, but I, from a parent perspective, being a parent myself, I can completely understand.
Right.
And especially when you're out in the community, you're not going to have your child have this complete breakdown.
Wow.
That's so
Right.
challenging to watch.
So
So go ahead. What were you going to say?
no, I mean, I'm just thinking like, so what do you do? I mean, that's, I guess, that's from the assessment. Then like, how do you actually intervene, or even like, and what do you see that actually works out in the field or in the literature? And um, maybe examples that, I don't know, take home examples, or is it, yeah. Like, I'm
That's
wondering, is this too delicate to even give take home examples?
I think it depends on the severity of it. So if you have a child who's clearly choking and gagging when you are presenting certain foods, then that might not be an area where we tell the parent, no, let's have more professionals before we move to where you're implementing that.
Yeah.
And we make sure that that parent training component is a huge part of it. So they're coming in and watching what we're doing before they try to do it at home.
Right.
Now, if you just have a child who's selective, like they eat, so I've had children like this too, where they eat a variety of food, but they might not eat any vegetables,
Hmm.
but they'll eat variety of fruits and other things, but they might not eat or they might not eat foods that are certain colors. Now, if it's something as simple as that, then we'll start with a plan that, systematic exposure. So we have so many different strategies within research that have been effective, like positive reinforcement. Something called this escape extinction is used a lot in feeding research, where you continue to expose and not let them essentially gain access to what they want. We also do
Hmm.
we also ask parents, like, okay, if we're going to do a feeding intervention and we did a preference assessment, let's say for example the child loves gummy bears, for example, we'll use something called the Premack principle, and it's just that's basically like grandma's rule in more layman terms, like if you eat this then you get access to them.
Okay.
So if you take a small bite of a broccoli, for example, then you'll get two gummy bears, because we always try to keep that reinforcement rate very, very high until we get success where the child is consistent.
Because the key is to just expose right now.
Yes, exactly. The key is to expose and be consistent. So if you're going to do something, so it can't be 1 week I'm going to try broccoli, next week I'll try like cucumbers. It has to be like, let's make broccoli successful before you move to a new food. So that is another area where we tell parents that, or what we'll do is like we'll have single exposure. So we'll have like a non-preferred food on a spoon with followed by a preferred food. So we'll have like a tiny piece of, let's say, a carrot followed by a big piece of a cookie. And then they have to first eat the carrot before they can get access to the cookie. So it's also like how you're presenting it too. It could look very different from child to child. So
Hmm.
you might have some children who can only tolerate single exposure, and some children who can have multiple non-preferred things and one
Hmm.
preferred thing. And there's research on really presenting it multiple different ways where it can be successful, but it's just biggest thing with behavior analysis, just that individualization, making sure
Exactly. Yeah.
success is individualized based on that child's preference and how they learn best, essentially.
Right. I imagine that from what you're saying, you're very sensitive to the individual, and you probably study the child
Yeah, it's
first.
not
Yeah.
like, yeah, it's not more, where group research kind of looks at like a group of individuals and how they perform. We look
Right.
at every individual as its own and look at the intervention, how it's affecting that particular individual, and
I feel
how
like that's the way to be effective.
right. It can
Yeah.
be a lot more work, obviously, because
Right.
you're every individual has their own intervention going on, and even if two people are working on the same thing, it could look very different from person to person.
Right.
Yeah.
Right.
So, and that's one of the reasons why I love this field, because one of the only fields that I've found that really looks at a person. It's a very holistic approach, I feel, in a lot of ways, because you're looking at the whole person and
Hmm.
not just, okay, I'm going to try this strategy because it worked for somebody else.
Right.
If it's not working for you, that means it's not the best strategy, and that
Right.
you modify in how that person is learning.
And I'm also thinking of the fact that just autism in general is such a spectrum.
Yes, absolutely.
Just, by definition,
Right.
that, it's actually, I couldn't even imagine it before you and I started talking,
Yeah.
the complexity of it. But yeah, it's very, very complex. I now know.
Yeah. And it's funny you bring that up, the spectrum part of it, because we we had some of that dis- distinction when we had more of those diagnoses. So we had, it used to be ASD, pervasive developmental disorders, Asperger's, but
Hmm.
now it's no longer diagnosed that way either. It's just autism, and it's mild, moderate, or severe. It's like based on levels of autism. So in a way, in some ways that's a good thing, because you can kind of say, like, all right, this person is clearly exhibiting signs of autism based on these criteria. But somebody with a sort of that PDD diagnosis, or pervasive developmental disorder, can have a lot of those similarities but have less challenges in some areas.
Hmm.
So sometimes it's a good thing to put that distinction, sometimes it's not. So I haven't found, and if you ask one person to another, they'll say, yeah, it was better when we had those multiple diagnoses, and some
Hmm.
people, right now, this is so much better. And I'm not a diagnostician. As behavior analysts, we're not allowed to diagnose, which
Okay.
sometimes can be because we treat children on the spectrum all the time. Sometimes it can be a little challenging why we can't be the first people that see this kid coming
Yeah,
in.
it's
And
kind of limiting because, like,
yeah,
you are an expert in this.
right. So as of right now, at least, we are not. But if they come in with a diagnosis from a developmental pediatrician or neurodevelopmental physician, then within the reports you'll see levels of autism based on the
Okay.
assessments.
Yeah, it does sound like, now that you explained how now, it used to be separated, and now it's it does, I could understand how it could complicate things.
Right.
Um,
And
yeah. And
parents
then
sometimes have a
I'm
challenge with that
I'm
too.
sorry.
Parents sometimes have a challenge. I mean, just getting the diagnosis of autism,
For
it
sure.
can be, challenging for a parent to hear. That's because that's a lot, there's no cure for autism, as we know. There's no applied behavior analysis is really the only evidence-based intervention that's shown to be effective, but there's so many other interventions. So the realm of information is unlimited, but what to
Mhm.
do and what's best for your child once you get that diagnosis, that's a process that parents go through, which I can imagine can be very challenging as
And
well.
it probably changes also with age. Like, one thing that used to work very well at, let's say, 5 years old might be very different for an 8-year-old, just because an 8-year-old is nothing like a 5-year-old. I mean, it's just, so
Yeah,
it's kind of like always, keeping your hand on the pulse, like your finger on the pulse, and like just constantly being on top of things, which is a challenge, which is not easy.
absolutely. Yeah, so within realm of interventions based on the medical model, that's why we do assessments every 6 months. We make sure that every six
Interesting.
months we're reassessing and developing a new treatment plan that meets the child where they are after 6 months of therapy. Within a school model, typically you have students with IEPs, and that's usually you make changes. And even in that realm, a lot of parents don't know what to ask for. What are going to be
Hmm.
the best services for my child? So,
Hmm.
really advocating for that
Right.
and making sure that the placement is appropriate, because a lot of public schools now have programs, fortunately, especially in New Jersey. Um, but that quality of that program is going to vary, right? Depending
For
on where
sure.
the child is. So, unfortunately, some of the social economic demographics and all those components really go into that too. Like,
Hmm.
culturally speaking, like I have a lot of clients whose first language is also not English. They're Spanish speaking. They're coming into this country. They might have just moved and they have children, and now their child has a diagnosis of autism.
Hmm.
It's very challenging for parents to, and I mean, luckily we live in a state where there is a lot of resources. I will say New
Right.
Jersey is one of the best in that area. But you
Interesting.
go to more rural
Yeah.
states, it's treatment doesn't even exist right now. So it can be very challenging.
Yeah. So that's where, public health promotion needs to come in and teach. And yeah, the yeah, it's like upsetting to hear this. And unfortunately, it's also kind of the expectation. Um, the some of the long-term or potential long-term outcomes or benefits of early intervention, um, and strategies in improving feeding and eating behaviors, uh, on the autism spectrum from your experience. Could you maybe elaborate on that? I have to also just say specifically with that question, the early intervention. Uh, I've I recently met
Mhm.
a mother
Okay.
of a child who was diagnosed with autism at a very, very early age. And I'm just sitting there listening to what she has to say. And I'm thinking to myself, how awesome are you
Yeah.
to like get your kid what he needs? It's specifically, it's a boy, what he needs at such an early age, because it's like you even mentioned it yourself. It's kind of nerve wracking, even just going to get the diagnosis. It's like, I don't want to hear it. I don't want to see it. This is like too scary. So
Yeah.
there's that. There's also like just picking up on it because it's still a very, very young child. So yeah, I'm curious. I just couldn't stop thinking when she was telling me like how amazing she is.
Right.
And so yeah, from your professional perspective, what are the benefits and what interventions are there that really you see work for early intervention?
Absolutely. So, I mean, within early intervention, so the model we have, especially in the US, is early intervention starts as early as 12 months. I mean, if you feel that your child is really not meeting those developmental milestones, and it's a state funded program. So you go through that system, and early intervention will come in, they'll do their own assessments. And typically they have occupational therapists, they physical therapists, speech therapists that will come in. And then they have what we call developmental interventionists. So those typically don't do, they tend to not be behavior analysts typically. So what happens is with early intervention, it's more we're working on play skills, some initial receptive skills like following a direction. Like if you tell a child, especially from a safety concern point, if you have a child who runs, you want them to be able to come back when you're asking them to come here. So we work on like those simple initial skills that are developmentally appropriate at that age. But then, and then from that OT speech perspective, they're working on the fine motor, the oral motor, um, the language, the communication. And then we typically, as behavior analysts, sometimes we don't get them till the age of 2, sometimes even 3, because early
Okay.
intervention lasts till the age of 3. And then we go into the ABA model. So that intensive ABA model, sometimes for some parents, they they don't get contact to that till maybe 2 years of age, 3 years of age. And some parents don't get the diagnosis even till the age of 3, because a lot of times pediatrician will be like, okay, they're still young.
Right.
They're, and I've heard this from so many parents, like,
Like
oh, they're
wait it
too
out.
young, wait it out. They might just be slower to develop communication skills. And that happens a lot too, because there's specific indicators, but sometimes some children just develop at a later age,
Hmm.
communications, especially with boys. We see this a lot where their communication skills are later developed rather than at the age as most developmental milestones are supposed to be.
Hmm.
So that can also be challenging because it can manifest into further concerns if they're not getting that diagnosis. So luckily
Right.
with early intervention, you don't need a diagnosis, but they have that specific criterion. You have to meet certain deficits to get early intervention as well.
Okay.
So that always is very helpful, especially, for, like, let's say if you have a child with feeding concerns, like OT will work on like some of those sensory processing areas.
Hmm.
So I'm not an occupational therapist, so I won't speak too much on that, but
Hmm.
they kind of look at feeding challenges from like across all the 5 senses and expose the child to different foods. Like, do they let them tolerate smelling the food, putting the food to their mouth, putting it to their lips, things like that. And then from a speech perspective, they'll work on looking at like what are the functions in the oral motor that may, so are they chewing correctly? They'll look at a lot of those functions, like are they gagging, or are they, when they're chewing in their mouth, are they moving it from side to side? All
Hmm.
of those components. And then from a behavioral perspective, we'll look at like where's the lack of selectivity. So is it just because they've gained access all their life to what they want, and this has
Hmm.
just become a pattern, or is it because the challenging behavior is so much more um, interfering with their lives that parents are just like, I'm just going to not address feeding at all because I don't want to see the challenging behavior. So in a way, it's like some negative reinforcement on the part of the parent
Correct.
because they get to
Right.
escape not having to deal with that tantrum essentially that occurs. So there's so many different ways, and there is a lot of research from all different areas too. And that can be challenging for a parent to figure out like, okay, what's going to be the best approach for my child.
Right. And so like seek out a professional that you trust.
Exactly.
And even if it takes a few visits, I've heard things like just specifically in the sports field, oh, I didn't go to physical therapists. And I'm like, okay, but there are some that are amazing.
Yeah.
Like
Yeah.
go and because if you need help, absolutely go get help and find the right person for you,
Yeah.
and for your child in this case. Um, and so you would say the earlier, the better.
Absolutely. The earlier the better, and some of these feeding challenges, it's funny, can be indicators too. So your child, most children, like I've had students at the age of 3 that are still drinking out of baby bottles because they refuse to let that go. So I've had
Okay.
parents just ask me to work on that, just getting them to drink from a regular cup. And
Hmm.
that could be part of our feeding intervention, even just exposure to different types of
Yeah,
cups and removing the baby bottle, because with the baby bottle, as we all know, that can affect oral motor development
absolutely.
the longer you drink out of those.
Right, because
The
of the
long,
way the nipple presses against the
right,
teeth. Yeah, yeah, yeah.
exactly. Even the pacifier, parents have
Hmm.
real difficulty removing that. So if a child has a pacifier, and I think in most pediatric research, from what I've seen, at the age of 2, they really shouldn't be having a pacifier because it
Hmm.
really affects your oral motor development as
Right.
well. So if a child has it till the age of 3, 4, because parent is just not able to remove that due
Yep.
to the increased problem behaviors that happen,
Yep.
that can create feeding challenges in the future
Mm-hmm.
too.
Mm-hmm.
So it could be as simple as working on that and exposure to different types of um, drinking out of bottles, removing the pacifier, like those types of things too. It could just be as simple as that to increase some of the feeding.
And so I'm, as a parent as well, I'm thinking of how much anxiety it can trigger for some of the parents. And it goes back to what I was saying a second ago. Like, again, as someone who's not an expert, for me, it sounds like it is so crucial to seek out the professional that will support the parent and the child as best as possible. Because even, I mean, I'm thinking of different situations that I'm aware of, and the child's behavior and tantrum behavior can actually be very triggering for the parent, and literally too much for the parent to handle. And so, absolutely go out and seek professional help so that you can also feel supported as the parent and get your child the best care that he or she needs.
Yeah.
Um, so, is it possible, because people not specifically from New Jersey are going to be listening to this, and
Absolutely.
if anybody does have any specific questions, and I'm sure you and I are going to talk again, and I'm going to get you back on here because you're really a wealth of information. So I'm wondering, is there a way to reach out to you that is comfortable for you,
Yeah,
whether it's
absolutely.
social media or website? And I'm of course going to link everything.
Yeah. So I have a very small company right now. I just provide consultations for schools currently through the company. Eventually, I will go into the insurance-based market. I have not approached that as of yet, just because of the time component and what it takes. um, but the company is called Neurodiversity of Northeast. I'll put it in the chat as well. And my email is on there. The website has a link to get your first consultation for free. So I'll put this all in the chat as well. And I'll send you a follow up email with all the resources. So I have created a list of resources for you, research
Mhm.
articles that specifically
Amazing.
eating. So I'll email you those components as
Amazing.
yes. Absolutely. I'm happy to answer questions. Now, I may not have answers to all the questions,
But
but
at
I'm
least,
going to do my best and guide you to the professionals who may be even more knowledgeable.
right, because I'll tell you what, I think that the, saying goodbye to you now and someone listening might be like, wait, I have to talk to this person. And, I need more information, because really it's the information you provided here today is so, so important. And I'm so grateful that you came onto the podcast and you're getting this, the awareness to rise. So thank you. Thank you, Dr. Hoyle.
Thank you for having me. This was amazing. And
You.
you're a great interviewer, I will say.
Thank you very much. It's
You
just
feel
that you're
very
really, really
comfortable.
fun and fascinating to talk to.